Not a Zoom session. Oh, just sit down and be quiet. All right, so I'm going to record today's session, and we're going to carry on with spinal cord injuries for our patient or discussion today. So when we're talking about different types of spinal cord syndromes, keep in mind that there are a couple of phases that you need to be aware of. One's the acute, one is the subacute phase. And basically, the acute phase of particularly of a cervical cord injury, but of any type of cord injury, will often result in your patient not being able to breathe sufficiently. Especially if the diaphragm is impacted. We're going to have a huge problem with our patient not having an adequate respiratory rate and or volume. The other thing to keep in mind is, again, as I shared with you in class on Tuesday, I don't teach you cranial nerves because you're not going to remember them. But what is important, Landon, is that you understand that you now begin to assess where the patient's ability to feel, as well as the ability for the patient to move, where it starts and stops when you've got a spinal injury. The higher up on the body, the higher the degree or the higher the location of the spinal injury that's going to be. Here's the other thing that's important to remember. When you're dealing with patients that have trauma injuries, one of the things that is critical for you to know is that these patients are going to be at even greater risk of hypothermia than would patients that just have a normal type of trauma and that they're losing blood. The reason being is that within cervical spine injuries in particular, but any injury whatsoever, you're going to get vasodilation. And so you're going to lose that circulatory effect of the heat going around to the body. So these patients, you got to be really aggressive in keeping them warm as well. Now, as we'll talk about in just a little bit, one of the things that happens with patients that are in spinal shock or shock that comes about as a result of a spinal injury is going to be the fact that in patients, normally when we're talking about patients in shock, Bella, what would you expect in the compensated phase of your patient shock? What would you see as far as the blood pressure and the pulse? Okay, and what will your pulse be? Elevated. Yeah, very good. So in compensated shock, pulse goes up. Compensated shock, blood pressure is going to be either normal or elevated. With patients in spinal shock, understand that their blood pressure can actually drop because they've got massive vasodilation that's going on here, but their heart rate will be normal or even slow. That doesn't mean that our patient has already progressed into decompensated shock. What that does mean is that the signals from the body up to the brain and then from the brain back to the body that would normally recognize, ooh, I got a dropping blood pressure. Therefore, the brain says, okay, I need to secrete some epinephrine, I need to secrete some norepinephrine, and we need to cause vasoconstriction and raise the heart rate. Now, basically that is going to not be possible, okay? Not going to be possible. Now, when we're looking at this, if we have below the cervical spine area, what type of symptoms would you expect to see with these types of patients? This is your all's part. Numbness of the extremities. What else? So we can have either loss or loss of control. So, for example, if I want to reach over here and pick up this bottle, I can perfectly do that. If you've got a patient that has below the C-spine of an injury, they may have a little bit of ability to still move around, but their ability of coming over here and being able to pick up a bottle or do fine motor skills may be negatively impacted. So that's one of the things you want to kind of look at. Here's the other thing. Remember, C-spine, we're really concerned about nerve damage coming through to the diaphragm. Thoracic nerves also impact the chest wall muscles. Why might that be a problem, Landon? Yeah, they won't be able to breathe. Or they won't be able to breathe with a decent enough tidal volume, okay? So again, keep in mind that any kind of spinal cord injury is very, very concerning for our patients. Now, obviously, the lower down we go on the cord, the less likely it is that our patient is going to have catastrophic, immediate life-threatening injuries, but they can definitely develop later on. Bella. Ooh, yes. Why? Yeah, you do. Remember what controls our bladder? Say it again. Muscles, yeah. The bladder is just a big, well, not big, okay. It's just a muscle that's shaped like a container. So, yeah, you're exactly right. And so you are also right in the fact that if we have severed or we've damaged a muscle or a nerve that feeds into that particular area, then most definitely we could have our patient that would be incontinent of bowel or of urine. Now, here's the other thing, okay? You probably learned this in EMT school, but you may not have learned why. In males, we will often see a partially erect penis. Why would that be? And why is that a bad sign? And that's called priapism, by the way. So why is that a bad sign for our patient? Well, definitely we've got a spinal injury, but it's severe enough now that basically the communication to that part of the body has been severed. And now remember, what did I say happens to the blood vessels when we cut off communication to the brain? Say it again. They dilate. They dilate, okay? And that's what leads to the partially erect penis. That is a very, very bad sign for our patient because now they're not able to maintain perfusion to the organs in that area that include some of the bowel as well. So that's the reason why that's coming in. Very good observation. Now, again, when we're looking at this acute phase, this is what the direct impact of the injury that has caused this. And much like we were just talking about, when we're looking at thoracic types of injuries or lumbar types of injuries, this leads to potentially for a patient to be a paraplegic, lower extremity, or loss of bowel and bladder control. In the subacute phase typically takes place about a month after the patient is injured. In this type of situation, now the flaccidity or the weakness or the inability to be able to move or to use the muscles now begins to be replaced by really severe, very painful muscle spasms and stiffness. And what this is the body's ability to try to repair what's going on. Now, in minor spinal injuries, well, let me back up. We used to think that in all spinal injuries, there was no potential for repair. We thought it was kind of like the heart, that when the heart's damaged from not having enough oxygen and infarction occurs, the tissue dies off and it no longer works. But that's not exactly true now. Now, we know that in major spinal injuries, the spine does not completely reheal itself. But we are seeing some things, especially with some of the new treatments that are coming out. Basically, what happens is that the spine can begin to heal itself and to regain some function. In that process, that's why what we see in this in this subacute phase of the healing process is very, very painful for your patient, and they have this sensation, but it is always going to be pain. They still don't have good fine motor control if they have any movement whatsoever, but if they have complete paralysis, the muscles will still begin to spasm, and their reflexes to what the body is trying to do may become very, very exaggerated. So some of the things that you need to be aware of as far as different types of injuries, different types of illnesses, let's talk about that right now. So basically, the first one we're going to talk about is anterior cord syndrome. In anterior cord syndrome, this is going to be caused by fragments of the spinal column itself, the protective mechanism, the supportive mechanism of the back, breaking off and impinging into the anterior part of the cord. Now, where would we find the anterior part of the cord? Aziz, when we say the anterior, what are we actually talking about? Yeah, what part? Now remember, the spinal cord is in the back, but what part of the cord is actually damaged? Let me make it a little bit easier. Is it the front part or the back part of the cord? It's the front part of the cord, okay? Now, we can't assess the cord at all because we don't have access to it. It's covered by the spinal column itself, okay? What we're able to do when we palpate up here at the neck and down through the back is that we're able to feel the posterior part of the spiny processes or the spiny extensions of the spinal column itself, not the cord. So that's the backside of the spinal column. With anterior cord syndrome, it is actually the front part of the cord that's affected. Now, the problem is about 75% of the blood flow that the patient receives to their spinal cord is on the front side. And that's why this can be a very serious type of injury that comes around. If this is disrupted, either by the potential, now it's possible that a patient could literally have anterior cord syndrome not from a spinal injury, Muna, but actually from atrial fibrillation. Why would that cause it? Why is it possible that atrial fib could lead to anterior cord syndrome? Well, definitely not enough blood, but the question I'm asking is a clot, okay? Remember, one of the big side effects that we're concerned about with patients who have AFib, uncontrolled AFib, is the development of a clot because the atria just kind of sits there and quivers, and blood is not fully ejected from the atria, and when blood sits, it has a tendency to clot. Now, that's a new place that you need to remember that a clot can actually go to. Most of the time, Ryan, when we see patients with anterior cord syndrome, it's going to be as a result of part of the front of the spinal column itself breaking off, pushing in on the blood supply, and thus leading to the exact same problems as what we would see either with a patient having an MI, if it doesn't lacerate the blood supply, it occludes it and it reduces it, or it occludes it entirely, or even worse, it goes in and lacerates particularly the arteries that affect and go directly to the spine. Right.
For a clot, can that end up anywhere along the spinal cord? Like end up along the C-spine too?
It sure can. It sure can. Now, clots in the spinal column, I'm sorry, the spinal cord, are rare, primarily because generally the clot is going to get stuck in either the brain, the heart, or the lungs first. But it is possible. It is indeed possible for that to happen. I've heard of a couple of, I've never had a patient like that, but I've heard of a couple of incidences of patients that need that will have that. Now, the nice thing about that is that can be treated if they get to it early enough, okay? And they'll treat it the exact same way you would if you had a clot in the brain or in the lung. They'll give the patient blood thinner. Bella. Ooh, okay, let's think about this, all right? Think about, let's kill two birds with one stone, all right? So here's our cord. Let's say that our artery that's coming down the cord, the front part here, is clotted off, or we have a fracture in the spinal column itself, and now it's pinching in on the artery. What do you think the initial symptoms would be, and how do you think that they might progress? That's a really good question. Muna. So they're going to begin to feel some numbness. Yes, what else? No, heart rate won't go up. Remember, with spinal injuries, generally, if a patient's going to go into shock, heart rate will not go up. What else? Gradual what? Gradual loss of sensation. It's the same thing as numbness. Aziz, what'd you say?
We would have like a set point, and like below it, it would be they wouldn't be able to control it.
Yes, this is the key thing with spinal cord injuries, is that you need to identify, coming right back, putting what you said with Muna, with what Aziz said. This is why it's important that when we are doing an assessment on a trauma patient, we need to find out, do they have distal PMS, which stands for, P is what? M? And sensation. That's that S that comes into play here. So we're assessing and we're checking to see the patient has PMS. And keep in mind, we do this always prior to a mobilization of a patient, whether it's spinal immobilization or a fracture immobilization, and we do it immediately after. If we have a loss of sensation, now we've got some additional work. We don't just simply mark that off on a box. What we do now is that we begin to work our way up. You can simply take anything like an ink pen and simply be saying, can you feel that? Okay? No, you don't feel that. Don't let them look while you're doing that, okay? Because basically the anxiety of having some type of a severe spinal injury is going to lead them to say, Aziz, oh yeah, I can feel that. But have them close their eyes and work your way up. Start at the feet and then work your way up as far as where they're getting sensation. When you find the point of where sensation stops and starts, take your ink pen and mark it. Why would I tell you to do that?
See if it progresses.
To see if it progresses. What might cause, in particular in an anterior cord syndrome, what might cause sensation loss to progress?
There's more fragments.
It's one thing. What else? If a clot moves, that's another thing. What else? It's kind of related to what Devin said. If there's more fragments. What would be the third thing? More what? As a result of what? Yeah, but think about from the mechanical side, from the anatomical side. What might cause me to be able to feel here, and now all of a sudden, and you're right, more tissue would begin to die of the spinal cord, and now when I get to the hospital, I can, I've lost sensation from here to here. What might have caused that? Increased pressure on the cord, yes. So that pressure could come about, number one, as movement of the fragment that is now pushing more. So keep in mind that within your artery, let me see if I can draw it here. So, nope, wrong color. So as we've got our artery here, if we've got part of the fragment that is impinging on that, that's going to reduce blood supply. And so we're going to begin to see signs and symptoms. If when we get to the hospital, now that the fragment has moved into that area, now we're going to see even more movement of loss of sensation going up the patient's chest. That's important. That's why we want to mark that sensation where that line is as part of our secondary assessment. Ryan.
Is there anything we can do to prevent a fragment from
A couple of things that we can do, nothing that is definitive, okay? So you and I don't have x-rays, so we can't confirm or eliminate whether a loose fragment is there. So that's why, based upon a patient's signs and symptoms, that's what we typically will move off of for our patient. The second thing that we can do is that we can be really, really particularly careful as we're, number one, immobilizing our patient. Number two, in particular, we need to be careful that the patient has as smooth a ride into the hospital as possible. Remind your partner, don't hit the railroad tracks at 45 miles an hour, okay? The third thing that you can do is that, and this probably will not be in your protocols, but it would be definitely something that I would tell you to consider about the possibility, would be the administration of Solumedrol. Now, what is Solumedrol? It is a steroid. What do steroids do in the realm of trauma? When we reduce inflammation, we also reduce what? Devin, you are on fire today, man. I like this, Devin. Okay? So yeah, we reduce swelling. When we reduce swelling, we take some of the pressure off of those arteries. And so now, here's the downside of that. When's that steroid going to start working?
Not for like 20, 30 minutes.
More like not for 3 or 4 hours. Okay? But remember, when they get the patient at the hospital, there's going to be a lot of things that are going to be going on with the patient. Okay? And so getting that steroid on board, much like the studies show that we know that when we've got a patient that has an asthma attack or an anaphylactic reaction, we know that if we give a steroid to those particular patients, still not going to act, Landon, for another 2, 3, 4 hours. But Rihanna, the survival rates of those patients that get the steroid pre-hospital show that the patients with those medical conditions are as much greater than the ones that wait and get it at the hospital. So again, call your med control if it's not included in your protocols, and it's probably not going to be, and ask them about the administration of whatever steroid you're carrying. Usually it's going to be Solumedrol. Taki. All right, let's think about this now. What class are we in right now? We're in trauma. Okay, good. All right, see? Shows how smart you are. You answered your own question. All right, good. Now, with anterior cord syndrome, your patient will often be able to feel vibrations and pressure. So that's why it's really important that you are assessing and finding out, can the patient sense pain? So you may want to push a little bit deeper when you're assessing on the patient's skin, okay? That's anterior cord syndrome. Now we're moving into the central part of the cord itself, away from the interior, not to the backside, the posterior, but the central. The interesting thing about central cord syndrome is it makes up about 75% of the spinal cord injuries that your patient is going to see. The most common mechanism of injury that leads to central cord syndrome is going to be hyperextension of the patient's neck. And what mechanism of injury would actually cause hyperextension of the patient's neck? Say it again. Not T-bone. Yeah, hitting from the back, having that neck go back over. That's why it's really important, guys, that you don't get cynical. At one point in time, I got really cynical about particularly low-speed motor vehicle accidents because always these patients would, oh, my neck hurts, you know. I always called it pulling the insurance muscle, okay? And so the thing is, you gotta assess these patients closely because you may have 100 patients that don't have a central cord injury, but that 101st patient might. And guess what? That might cost you an awful lot of money. Now, the big thing that we see here with central cord injury is that we're going to have edema from the inflammatory process more so than we would from blood. Most of the time, the spinal column itself is intact. So there are no fractures, there are no dislocations. It is not coming from the bones of the spinal column, but instead it's coming from tears, tiny tears inside the cord itself. Now, the reason that we don't have a lot of bleeding is because those tears are really, really small. But again, remember, when the body has trauma, basically what comes about is that the inflammatory process always begins, and part of the inflammatory process is it's going to lead into increased in swelling and edema. And that's what's going to now begin put pressure on those nerves. With central cord injury, this is really common in patients that are over the age of 65, and especially, again, older patients that have hyperextension, as well as any patient that has any type of osteoarthritis of the spine. Now, when I talk about osteoarthritis of the spine, what am I actually talking about? What is that? Say it again.
Is it where like the fluid in between the bones like starts to diminish? You get like bone on bone.
That can lead to osteoarthritis because you begin to lose, remember, what sits between each one of the vertebrae? A disc, okay? As we get older, we have a tendency to lose some of that fluid. And in particular, we see this in females of Caucasian and Asian descent, that accelerates, especially now coming into play here, Devin, with what you said, is that now we begin to get bone on bone. When we get bone on bone, now it begins to crumble and we lose some of that flexibility for our patient. And this is even more true for our patients that have kyphosis of either the neck or the upper back. These folks are at great risk if they get struck in the back of their car. And again, they do this. Now those patients are going to be at great risk of having central cord syndrome. And this is another reason as to why we never, this is one of those nevers, we never force them down to the backboard. Right.
The bone on bone, can that lead to just like in normal, like every day, just walking around, can that lead to like fracture and burn?
Yeah, because basically what we're doing here is, again, as we get older, that's just a natural part of aging, but it is accelerated in females, particularly after menopause, because calcium begins to wash out quicker. And so when we lose calcium, we lose structural integrity of our bones. And so it is possible, to have what's known as a stress fracture. And a stress fracture comes about not as a result of any type of overt trauma, but stress fractures happen as a result of just the actions of normal daily living, such as walking around. Because remember, when our foot, you don't recognize it now because we don't think about it. It's not causing us any pain. But when your foot strikes the ground, you're exerting pressure on your bone, on your skeletal system. And remember, when we said that we had patients with axial loading type of injuries, what did we say caused that?
So much weight.
Tell me more. Bella, what'd you say? Yes. So you jump from a height and you either land feet first or you land head first, and it is possible, especially if you land feet first, to have no injuries of your lower legs, but you can have an injury of your spine. Because remember, that energy is transferred all the way up the bony processes of the skeleton. And again, because of the old song, if you never heard it, look it up. You know, the ankle bone's connected to the leg bone's connected to the knee bone. And there's a lot of truth in that, especially when we're talking about axial loading injuries that can come about, again, if we lose that calcium, just the simple act of walking or more frequently twisting can cause a patient to have a fracture. Bella.
Skeletal system or like the discs or like the cord absorb the energy that we come
I'm not sure if I understand your question. Say it again for me.
like all the energy that's coming in, like the pressure.
Mm-hmm.
Does the skeletal system absorb it or like do the discs absorb it?
So keep in mind, the entire body is actually absorbing the pressure. So let's say that let's say that you're up on the third floor and it's on fire. So you got a choice. I either jump out or I risk burning up. My line of thinking is I think I'd rather jump. I'm not in that position. I don't know. But I think I would rather jump. So I jump, I hang off, I jump, I land feet first. All the energy is going to be transferred through every muscle, every organ, and the skeletal system of the body. But because the skeletal system is the most dense, that's where most of the energy is going to be transferred. And so that's why you can come up and you would find that your patient would begin to have these types of injuries. And in that situation on axial loading, most of the time, let me ask you, would you expect to see an anterior cord syndrome or a central cord syndrome in that particular situation if you landed feet first? Why? You're right. Tell me why you're right.
Pressure goes up, and then the fractures is like all that pressure gets.
Yep. So remember, here's our here's our spinal cord. Here's the vertebra that is around it, and as the vertebra, as the pressure exceeds the ability of the vertebra to hold it, it breaks and it goes in. Now, what if the axial loading injury was from a diving injury into an empty swimming pool? Now, would you expect anterior or central cord syndrome?
Could be both.
Could be both. Could be both. Okay. Now we've already made the argument for the anterior cord syndrome, but how about making an argument for central cord syndrome? Why might your patient have both then? Okay, anterior and central.
If they hit their head, the pressure's gonna go down, that's gonna cause the anterior.
Yep.
It's gonna split.
Yep.
But if you go head first, it either hyperextend or hyperflex. That's what's gonna cause the swelling and the edema that causes the flexion.
Yeah, you're exactly right. And again, most of the time, central cord syndrome comes about as a result of flexion, okay? But, our extension. But we can also see it when it's flexed forward as well. And this is one of the reasons why I told you on Monday, when you're assessing your patient, look for signs and symptoms of what's called kissing the chest injury. We're going to see this more commonly in females than we would in males, but just simply because females generally, I'm not profiling people, but generally you will have more females that will wear lipstick than you will males. I'm not judging here. I'm just simply saying that's been my experience. So look for the possibility that there's lipstick down here, either on the chest or even down here on the abdominal area that you're going to get.
Obviously it doesn't say.
Say it again.
I said, where does the energy go after it passes through everything? Because obviously it doesn't say in the body.
No, basically it is transfer. Remember now, I land and the energy, let's say that I'm jumping, I land and I hit the ground, and when the energy reaches the end of my body, it's actually transferred back into whatever I landed on, whether it's concrete or snow or water or whatever, okay? Now, when we're looking at this, keep in mind that with central cord injury, what part of the cord is most often going to be affected? Cervical, yeah. So what kinds of symptoms would you expect to see in that situation? Or let me back up. Where would you expect to see the more serious symptoms? Say it again. Anything doing with respiration. Yep, you're exactly right. Anything doing with respiration. So that's typically what you're going to begin to see, okay? Now, if we have got a patient that has central cord syndrome as a result of edema, these patients have a really good prognosis of being able to regain most, if not all, of their normal function as the edema begins to dissipate. And this is going to be one of the reasons why getting these patients on steroids as soon as we possibly can is actually going to be a good thing. Devin.
I was about to say, can you give them a LASIK or something?
We don't want to give Lasix, okay? Now, in the past, what we usually did is that we gave a lot of Lasix, particularly to patients who were in heart failure. We don't give Lasix nearly as freely now as what we used to. Why do you think that might be? Well, you can draw out too much fluid, but generally that's not going to be the biggest problem. Bella, what were you going to say? Yeah. So the edema that we're seeing with the spinal cord injury is not going to be pulled out. Remember, what happens with Lasix is it increases the filtration rate of your kidneys, okay? The edema is up here. It never makes it down to your kidney, okay? And so that's one of the reasons. The other reasons, as far as like within heart failure, is that we're really, really concerned if we give too much Lasix, is that we're pulling off too many of the electrolytes, and in particular, the cardiac electrolytes, okay? So, Aziz.
You said we should give them steroids as soon as possible, but in a trauma
we're also afraid of like infection to the brain.
Yes,
So if we give them steroid, that's going to speed up the infection process.
potentially. Potentially. Now, here's the thing, and again, this injury may not kill them, but I'm not so sure I'd want to live the rest of my life as a quadriplegic. Okay? And now I'm not saying that do things that are going to speed up their death, but if I had an option, the infection will, as a comparison, will be easier to treat with antibiotics than will the destruction of nerve cells because of edema. So if we can get that steroid in earlier. So yeah, you're exactly right. I love the level of thinking you guys are putting in this. Yeah, we if we have a patient with a steroid, we give them it. It does make them more susceptible to infections. You know, I'm on a chronic steroid, a very low dose because of my kidney transplant, so I have to watch that closely. But in this situation, the greater danger for our patient right now is going to be the damage to the cord rather than the potential for an infection. Kind of comes back to that, we're going to treat what's going to kill them first. Very good, very good. Any other questions on anterior or central cord syndromes? All right. Brown-Séquard, okay? Brown-Séquard is caused by an injury to the spinal cord itself that could come about as a result of either trauma or some type of a tumor or a blood clot, okay? We also see this type of situation in patients that will have long-term untreated tuberculosis. With Brown-Séquard, it is not commonly seen right now as far as coming from a medical cause. The most common cause of Brown-Séquard syndrome is going to be penetrating trauma, usually from a gunshot wound or a stab wound that goes into the spinal cord. If your patient suffers from decompression illness, it can also add to that, and we'll talk about why that is in a minute. First of all, let me make sure. Does everybody understand what decompression illness is? Somebody tell me, what is it? Any divers in here? You guys would know more about. What does it do with the nitrogen? You're on the right track. Okay. So remember, when we go down, gases get compressed in our blood. So you're exactly right. We go down, gases, oxygen and nitrogen, because remember, we got more nitrogen in our body than we do oxygen. All right. Most of what you're breathing right now, nitrogen, not oxygen. That gas gets compressed. When you come back up, now if you come back up too fast, guess what happens? You get bubbles in your blood, nitrogen bubbles. What happens when you have bubbles in your blood? You don't have blood going through your vessels, okay? And so that causes an occlusion to the spinal cord as well. Basically, with Brown-Séquard syndrome, you get paralysis that's on the same side as the injury. Now remember, with the brain, we have ipsilateral control. Ipsilateral meaning the opposite side. That means that your right brain controls everything over here, left brain, everything over here. Spinal cord doesn't do that. As the cord comes down and it branches off, basically if you think about transecting or going straight down the spinal cord itself, the right side controls the right side, the left side controls the right side, the left side. So basically what you're going to see with Brown-Séquard is that you're going to get paralysis and loss of sensation on the same side, but you'll get loss of pain as well as temperature, sensation. You can't tell whether it's hot or cold on the opposite side of the body. Now, somebody tell me, how does that happen? What causes that? But what you're right. But why does that happen? What is the mechanism? I mean, those of you that are working like at horse tracks, this is a distinct possibility that you can see just simply because of getting thrown off of a horse. Even though most of the time it's going to be penetrating trauma.
Is it because of the side of the brain that controls that side?
It's not the brain. Remember, this is spinal cord injury. The brain is fine. Yeah, so the nerves are coming down. And remember, the nerves come down and they have a tendency to kind of, okay, so this right here is our cervical spine. Our nerves come down off of this side and branch out that way. Then our nerves come down on this side and they branch off this way. If I've got a GSW to the spine in right here, and I have direct trauma to the spine, then that's going to cause the paralysis and the loss of perception on that one side. Basically, by loss of sensation, what I'm talking about is that I can't, right now I can tell you my arm is on my leg. I can tell you right now my arm is out from my shoulder about 90 degrees. My arm is above my head. In losing that sensation, you may ask your patient, tell me where your arm is. I don't know, okay? Can you move your arm? Yes, I can move it. Now can you tell me where it's at? No, okay? So that's what we're talking about, in particular called proprioception. Basically what's happening is those nerves have been cut. That allows me to know where my arm is. But again, ladies and gentlemen, boys and girls, when we have trauma to the body, what else happens? Not necessarily in shock. This can lead to shock. Say it again.
The sympathetic nervous system, I think it can.
When we have trauma to the body, what's the first thing that happens?
Blood loss.
Not blood loss. I think you just said it. Not bleeding. Inflammation. Inflammation. Understand inflammation needs to be very important to you, because with inflammation also comes what? Edema, swelling. So now what we've got is we've got direct trauma to this side of the spinal cord, which means I'm losing some pretty important functions over here. But the body says, wait a minute. Miriam's spinal cord has been damaged. We must repair it. And so the white blood cells now begin to go in there. The immune response begins to act. Aziz, it begins to fight off any infection that would be coming in, and it begins to swell. So that's why we begin to have diminished perception and loss of pain, as well as knowing, is this hot or cold over on this side as well.
Why don't we just give steroids to all trauma patients?
You will. As it goes by, you will. Now keep in mind, steroids are not a harmless drug, but it would definitely, I think, in my opinion, with the early administration of steroids, that would be a really, really good thing. The other thing that you'll see, and you'll often see this primarily in college sports as well as NFL football games, is they'll talk about cooling the patient off. So we've talked a little bit about, and we'll talk more in cardiology about the pros and cons of therapeutic hypothermia for cardiac arrest patients. I don't think it works like they had hoped it would, but it works really, really well for the treatment of spinal cord injuries. Why? Because you get a sprained ankle, what are you going to put on it, heat or cold? Yeah, don't put heat on it, whatever you do. It's just going to make it bleed even more. You're going to put some cold on it. You're going to put ice on it. Well, that's going to be the same thing we're going to do to our spinal cord, okay? It's a little more complex than just simply putting ice packs on your neck or your back. So they've actually, many times will have to put the patient in an induced coma and bring down their core temperature. Taki, do you have a question? Okay, it'll come back. It'll come back, okay? Now, keep in mind that Brown Sakari can either advance or it can regress. If the damage is permanent and there's no way, and if it's severe enough, it will continue to progress, basically to where your patient will have complete paralysis. If it is temporary, it can now begin to come back and to heal itself again as that edema begins to go down. Bella. Basically, it would be, in particular, we would see this with like an impaled object. So let's say that a patient gets stabbed in the neck and the knife stays in place. That would actually work to the patient's benefit, because now what you've got is you're going to have not blood loss, because it's going to be tamponaded off by the knife. You're still going to have some swelling, but remember, swelling is temporary. So as we begin to bring that down, the big issue would come in is if it's like a GSW to the neck, it goes in, or it's a knife goes in and out, blood flow is reduced to it can be anywhere along the spinal column itself. I keep pointing to the neck. The blood loss comes in, and then we have necrosis of nerve cells, and those don't regenerate. Good, very, very good. All right, so any questions on that? All right, next one we're looking at is cauda equina syndrome. All right, basically what this is, it is a compression of a bundle of nerves that is located at the end of the spinal cord itself. Generally, basically what we're looking at here is well, you tell me. Okay, remember now, when we come down, we talked about this a little bit on Tuesday. The end of the spinal column is actually called what? What is the very end, also known as the tailbone? What is that called? Nope. Coccyx. There are no nerves in the coccyx part of the spinal column itself. Okay. Where it does end is in the where the cords, the nerves do end, is in the very, very lowest part of the lumbar area of the spinal column. What do you think, what type of injury, what mechanism of injury would lead to spinal cauda equina syndrome? A little bit louder, please. So it is relayed to people who originally spent long hours in the saddle with the up and down, that would lead into potentially pathological fractures that would cause that. So yes, because it's equina we're talking about, it was related to people. But today, the most common cause is you land on your tailbone. You land, you fall, you land, and you land not legs first, not feet first, but butt first, okay? And as a result, you get that compression, and now it leads into both primary trauma from the actual injury itself, as well as secondary trauma from bleeding, as well as from edema. Now, most commonly, if a patient is going to have this, it's going to come about as a result of some type of illness, such as cancer. So this is where we would see it more commonly with these particular patients. With these particular patients, the signs and symptoms that they're going to feel are going to be kind of like, you know how your arm or your leg will go to sleep if you sit on it? You get that kind of like needle sensation. You'll have that of the lower extremities. What's that? Or in your hand. Yeah, you get it in your hand or in the lower part of your back as well. Now, this does not generally lead um, into paralysis. But the other reason that we have the Latin word equina in there is that the path of these nerves would be the same pathway as if you had a person who was in a saddle. So basically, we would have that burning, prickly, feels like, and this would be chronic and constant. Okay, so this is not pleasant and it doesn't go away. There's really not much that you're able to do other than pain management. And this is one of those situations that can lead to the potential of a patient becoming addicted to narcotics if they're not really, really careful. Lower back and the insides of the legs, kind of like if you had been sitting in a saddle for a very, very long time. With these patients, they may also have chronic loss of bowel or bladder function for this. When you're assessing, now you won't do this, okay, but one of the assessments that will happen in the ER is that they will go in and assess the patient's rectal tone. And generally that involves inserting the finger into the anus, and if it is very flaccid, if it's basically just kind of open, that says that the body has lost the ability of that part of the intestinal tract, which is what can lead to incontinence of bowel. Cauda equina is not a common type of syndrome that you're going to come into contact with, but you need to be aware of what it is and what's happening with that. Ryan?
What can we do to treat?
With that, basically what you're going to do, if it is an acute onset, if this is the first time that it has been noticed by the patient, or if it comes about as a result of trauma, the big thing you're going to do is, number one, make your patient as comfortable as you can. Obviously, look for other life threats, especially if the patient has fallen from a distance. Now, it is possible, especially in older people, that if they fall and they land on their backside, they can develop this sensation as well. It's difficult in those situations to tell the difference between this and like either a hip fracture or a pelvic fracture. The thing that I would tell you to do would be to be generous with your patients with pain medicine if it's an acute onset. If it's a chronic onset, there's really not much that we're going to be able to do. We may be transferring these patients back and forth to the doctor if it progresses to where it becomes incapacitating the patients. Anybody else? So, syndrome that you're going to come into contact with and you're going to see on a regular basis is actually going to be spinal shock. Spinal shock is generally going to be a temporary, although it can be a life-threatening syndrome, that happens at the exact same time that your patient sustains a spinal injury. Okay, it begins with its onset right away, and symptoms generally will begin to present within about 30 minutes. It will often make it look like that the spinal cord itself has been transected. Now, when I say transected, what do I mean? What is a transected cord? Been severed, okay? And so basically with a transected cord disease, what would you expect to see on your patient? Really very obvious for that patient. Somebody help him out. No sensation or movement. No sensation or movement. And typically that's what we're looking at with this. The reason this is happening is all again because of inflammation and edema. It's putting pressure on either the nerve or the nerves and or the blood supply that is supplying the nerves, and now it's cutting that off. This again results in paralysis as well as your patient does not have motor reflexes. Now, we're not really good at checking motor reflexes in our patient because we're not entirely, so for example, if we're checking reflexes in the elbow or in the knee, we're not entirely sure of where we would tap our little percussion hammer, and that's okay. What could you do, though, to check for a motor reflex that is very simple to do and something you should be doing on particularly all your unconscious trauma patients? Say it again. Okay. That would help a little bit. What else? I'm sorry. Say it again. The funny bone. Well, now, yeah, we can do that, but we got to be able to hit the nerve at the right time. This is something that's really, really simple. You can do it with your ink pen.
Is it like you can rub your pen up their foot?
Yeah, you rub it up their foot, or while they're unresponsive, the palm of their hand. All right, and so that will help you to know if they have an automatic reflex to that painful stimuli. Okay. Typically with spinal shock, they're not going to be able to feel anything below the level of where the injury is. Now, understand that the obvious point of injury may not be where the largest amount of internal injury is for your patient, okay? Typically what we're going to do here, Rehan, is we're going to see this injury up in a high level, usually going to be either the thoracic or up in the spinal cord itself. Now, if this is true spinal shock, it will go away. Now, it may take a few hours, depending upon how quickly the edema goes away, as well as if there is a hematoma or there's bleeding that's impinging on that, or it could take weeks. Again, if we've got a hematoma that is there, think about how long it takes for a bruise to heal up on any of us. And so imagine now if that bruise were right on top of your spinal cord. And so it's going to take a while for that to be able to go out. The speed at which it corrects itself and heals is dependent upon how serious that the injury is going to be. Now, typically what you're going to see with these patients that are in spinal shock is that below the level of injury, the skin is going to be warm, flushed, and dry, okay? This is going to be where in your male patients, they may also present with priapism, okay? And again, this is all coming about because we have massive vasodilation of the blood vessels that are distal to the level of where the injury is. Spinal shock itself can actually lead into neurogenic shock, okay? And neurogenic shock is basically any injury, any trauma, or any type of a potential disease process that disrupts the brain's ability to communicate with the rest of the body, okay? And this is in particular communicating the autonomic functions of the body, which are the vegetative functions that we need to help to keep us alive. Our heart, our respirations, our digestive system. Taki. When I see what now in spinal shock? What do y'all think? Would you see altered mental status in spinal shock?
Yes. Yes, you would.
What's my favorite way to answer a question? It depends. Yeah, it depends on the mechanism, okay? Now, again, remember, your patients don't come nice, neat, compartmentalized with, oh, well, this patient only has spinal shock or neurogenic shock, or this patient is only a diabetic patient, or this patient is only a fractured femur patient.
Wouldn't altered mental status be a late sign?
No. keep in mind, and this is something that's really important, altered mental status is one of your earliest signs of shock, okay? Regardless of the cause of shock. You pick one, altered mental status is going to be one of the earliest signs, and including that sense of impending doom. That's a type of altered mental status. So it depends upon, does our patient also have internal blood loss that's going on internally as well? Because remember, with neurogenic shock, we're talking about an interruption, kind of like I used to use the illustration of telephone lines. Nobody has a telephone in their home anymore, including me. I'm an old guy. We did away with our home telephone years and years ago. But, okay, come on, man. 1990 called. They want their technology back.
How old are you?
I'm 22. Imagine that you had a cell phone tower that went down. Okay, so it's the same premise. Now, you can't communicate back to anybody, and nobody can communicate to you when your cell phone is working off of that particular tower. If we've got internal bleeding, then yes, we could have signs and symptoms of shock in addition to that type of injury. Now, when we're looking at this, part of the thing is that the brain does not sense what's going on below the level of injury. So, for example, let's think about from the cardiac perspective here. Bear with me, I'll try to make this make sense. When you got a patient in third-degree block, what's happening and what's not happening? To where? To the ventricles. So the SA node is firing, okay, but something's happened where? At the AV node, and that impulse does not get through. So that's what's not happening. What is happening in third-degree block? Say it again. What is happening in third-degree block? So we've already identified part of what's happening. The SA node is firing, but that impulse gets blocked. What else is happening? The ventricles are contracting. Why? Because they're not getting the impulse. Remember, that comes back to, if you go way back, remember 303? Those were good days, right? Anyway, that's that automaticity of the intrinsic pacing rate of the different parts of the heart. Same thing happens in neurogenic shock. The brain's sending out impulses, comes down the nervous pathways, but we got a break. And it can't jump over to this pathway that is now leading to the rest of the body. The other thing, the reverse is also true. Remember, the body has receptors, chemoreceptors, baroreceptors, that are always monitoring the body and sending messages back to the brain, okay? They're coming back up different pathways, different nerves, okay, not the same ones. They're coming back up this way, but if those nerves are lacerated, it can't jump the gap and get back up to the brain. So basically, the brain thinks, hey, everything's going great. It's kind of like literally in that situation for the brain, no news is good news. And as a result, your patient can be in shock, but the brain is not secreting what? What does the brain secrete in the presence of shock? It secretes epi and norepi. And Devin, why does the brain do that? Yeah. So we have vasodilation and we have a nice normal heart rate. But our patient obviously is in distress, okay? Now, this is basically going to be what we would classify as kind of like relative hypovolemia, no compensatory mechanism present. This is dangerous for your patient because they are not able to compensate for that. Signs and symptoms. Number one, slow heart rate. Okay, slow heart rate. Number two, low blood pressure. Number three, below the spot of injury, your skin will be nice and warm. Above the level of injury, your skin will be pale, cool, and diaphoretic. Why?
That's where all the blood is, isn't it? It's not the circulating around.
You're close. Taki. Now say that again. Don't think vasoconstriction yet. Think nerve transmission. What's happening from a nerve transmission site above the level of injury? Okay, I can go with that. Again, because most of the time what we're looking at in neurogenic shock is going to be spinal injury. But keep in mind that, again, what is happening is that nerve transmission is working as normal above the site of injury. So what would you expect in a patient that's in shock? You would expect the patient to be pale, cool, and diaphoretic. All right? Ladies and gentlemen, that's where we're going to stop. I'll see you this afternoon. This afternoon when you come back, got a little gift for you to deal with cardiology. We'll talk more about that when you come back this afternoon. So